This particular patient, if we used the DIPSS plus criteria, which is probably the most commonly used at the current time, would have several risk factors that would weigh in. Their age, being over age 65, the presence of anemia, hemoglobin of less than 10, the presence of symptoms, and the presence of greater than 1% blasts. This individual would fall in the category of being an intermediate 2 by that risk set of criteria. Features that that patient did not have that would be additional risk factors that would make someone high risk would include transfusion dependence, a high-risk karyotype. This individual had a mutation in the 20th chromosome, which is not a high-risk mutation, or the presence of thrombocytopenia. There are multiple classification systems and prognostic scores for myelofibrosis, and which one you can utilize is in part dependent on which of the variables you have available to you. The DIPSS you can calculate by your physical exam, your symptom assessment, and a complete blood count. The DIPSS plus we were able to calculate in this patient because we also had the chromosome analysis available, and this individual did not have a high-risk chromosome analysis. The MIPS 70 is for individuals under the age of 70. It is meant to potentially most inform for individuals who might be a candidate for stem cell transplantation, and one requires the next generation sequencing results to look for the presence of high-risk molecular features for such an individual. So we'd not be able to utilize it in this patient. In many patients with myelofibrosis, we are unable to obtain an accurate karyotype due to the fibrosis which occurs in the marrow. When we are able to obtain a karyotype, many of the prognostic data which has arisen is very consistent with what we have seen with other chronic myeloid disorders, including myelodysplastic syndrome and acute myeloid leukemia, where in particular complex chromosomal changes, meaning multiple abnormalities, deletions of chromosome 5, 7, etc., are all adverse or high risk. It is probably the minority of patients with myelofibrosis that have very adverse chromosomal abnormalities. However, they do tend to accumulate more chromosomal abnormalities as they progress towards acute myeloid leukemia. So that issue of clonal progression is reflected in the chromosomal abnormalities. Prognostic factors tell us how long we might expect an individual myelofibrosis patient to live. Now, many of these criteria from the past were generated based on retrospective data on patients with myelofibrosis that preceded the JAK inhibitor era. So we are not quite certain as to the relevance of these prognostic features and how they relate to our current medical therapies and outcomes. It is not clear that there is a specific chromosomal change which is linked with the outcomes associated with JAK inhibitor therapy at this time. That may evolve in the future, but at the current time is not a major component of our processes. I view that these prognostic scores are the most beneficial in helping us estimate survival and make decisions as it relates to the timing of stem cell transplantation.